The title of my talk is a little bit deceptive, I guess, integrating public health and clinical care using electronic information, but it does make sense, as you'll see as we move along. And so my first question is, how many people here know about Lake Wobegon? Yeah, that's okay. So people who know about it now can not listen to this next part. So for those of you who don't know about Lake Wobegon is an entirely fictional town in Minnesota, popularized by Garrison Keillor on National Public Radio. And it is known for having everything in this little town perfect. So everything is perfect. So the immunization registry is perfect, healthcare is perfect, education is perfect. Everything is perfect in Lake Wobegon. So now the rest of you can listen again. So I'm going to illustrate what I have to say today by telling you about integrating public health and clinical care in Lake Wobegon. With thanks to the Lake Wobegon Health Department, and those of you who don't, it's totally fictional, just give me a little slack, please. The health officer, the CIO, and the director of informatics, and also thanks to the Minnesota Health Department, Marty LaVenture, who is director of informatics, and he is a real person at the Minnesota Health Department and has been very helpful. So the national health issues impacting Lake Wobegon are no different than those impacting every other community. Medical errors are very common, lots of preventable deaths. The quality of health care, by any measure, the quality of health care is poor. And let's not mince words. When people say we have the greatest health system in the world, what they mean is that if you have insurance or other means of paying and you are very clever navigating the system and you really know what you're doing, it's possible to get outstanding health care in the United States. But the overall quality of our health care is not good. And on top of that, our costs are out of control. The rate of increase has moderated with our terrible economic problems in the last couple of years, but it's still consuming an increasing proportion of the GDP, over $2 trillion a year. And let me say that if we do nothing about healthcare costs, it will bankrupt the nation. And so since we're not going to let the nation go bankrupt, bad things are going to happen if we don't get healthcare costs under control. So what's the situation with health information in Lake Wobegon? Well, every person's records are scattered wherever they received care. So every time somebody goes for care in Lake Wobegon, various clinics and hospitals, records are left, and most of those records are paper. And the information sharing is not effective. It's cumbersome, expensive, time-consuming, and it doesn't work. And in fact, there's no mechanism to actually collect all this information from the various sources for use in patient care or anything else. And no one in Lake Wobegon has all their records, and no doctor of anyone in Lake Wobegon has access to all of any patient's records. And there's no institution that's responsible for dealing with this problem. And Management 101, nobody's responsible, doesn't get done. And if you think about it, there is no healthcare institution that's responsible for making sure that your records are available when you get care, all of them. And so therefore, your records are not available. And so we need to create those institutions. And so Lake Wobegon set forth two important goals: to integrate public health and clinical care by creating a comprehensive health information infrastructure, and to reduce errors, improve care, and decrease costs for both individuals and the population. And certainly ambitious goals, but achievable. And so their action plan had three parts. First, a review of public health informatics and how it's progressed over the last few years. Second, an analysis of key barriers and obstacles. And finally, developing an implementation path for health information infrastructure. So this review of public health informatics started with a definition and the agenda, national agenda that was developed at this 2001 spring consensus meeting of AMIA, and what's happened since 2001 and how it relates to public health informatics, how infrastructure relates to public health informatics. So what is public health informatics? I won't read you this definition. You can read it for yourself. But the important thing is to realize the contrast between public health informatics and medical informatics. Public health informatics deals with populations as opposed to individuals. It deals with prevention primarily as opposed to treatment. It looks at interventions along the entire causal chain leading to disease, whereas healthcare is focused on medical and surgical interventions. And typically, public health informatics, just like public health, has a governmental context because in this country, public health is typically a government function, although there are efforts to move it more towards clinical care. So where did public health informatics come from? Well, you can argue, but one of the early developments was something called EpiInfo in 1986, which is microcomputer software for epidemiology that came out of CDC. In 1994, CDC put out a system called Wonder, which allowed you to do queries to multiple public health databases. And this was a very early example of federated databases that actually could produce interesting results. In 1995, Andy Freed and colleagues wrote really the first paper in the field, How Information Age Technology Can Strengthen Public Health. In 1996, I worked with Patrick O'Carroll and Wally Wilhite to reporting on a course we had developed for public health advisors in public health informatics. And in 2000, I wrote an article in an attempt to define the field called Public Health Informatics, Improving and Transforming Public Health in the Information Age, which said, in essence, that informatics is unfamiliar to most public health professionals, which was certainly true at the time. And in 2001, the spring AMIA meeting developed a consensus national agenda for moving public health informatics forward. So what did that agenda consist of? Well, there were a lot of recommendations, which we don't have time to go through, but essentially they boiled down to two things. One, we needed coherent governance of public health informatics activities, including all the stakeholders, establishing and using standards, dealing with confidentiality policy, dissemination of best practices, and improvement through research. And we also needed training in public health informatics, basic informatics skills for the entire public health workforce, and advanced skills for decision makers, which is actually one of the things your new program is going to be doing, or is doing. So what's happened since 2001? Well, in practice, and it's worth remembering this, computers and internet access are now widely available to public health departments. Hard to realize in 2012, but in 2001, most public health departments had no computers and no access to the internet. There are CIOs at all state public health agencies. This is a new development. The Public Health Informatics Institute was established in 2002. The National Association of Public Health Information Technology is organized and then evolved. And there have been a number of projects out of CDC. You may recognize some of these names like BioSense, and hopefully you recognize Meaningful Use, which has public health components. And there's been a lot of work on standards. And CDC established a National Center for Public Health Informatics in 2005, changed it to an office in 2008, and I can't keep up with their reorganization, sorry. In research, a public health informatics research agenda was developed and updated at CDC. They did fund centers of excellence around the country. AMIA started, actually I started at AMIA, the Prevention and Public Health Special Interest Group, which has evolved into the Public Health Informatics Working Group. And interestingly, if you do a PubMed search on public health informatics, you'll find that before 2001, you will retrieve 6 articles. And from 01 to 04, you'll find 168 articles a year. And since 2005, it's been pretty constant, about 210 articles per year. So the field essentially developed from nothing to this relatively high level of productivity. So in learning, the Institute of Medicine recommended that public health informatics be included in all MPH programs, and this recommendation is now 10 years old. So, and certainly hasn't been implemented everywhere, to my knowledge. The CDC developed a set of public health informatics competencies, which have been updated a couple of times. With Patrick O'Carroll and other colleagues, we published a public health informatics textbook in 2003, which hopefully will soon be revised, although not by me. There has been a standalone public health informatics chapter, or there will be in the next edition of the textbook of biomedical informatics. That's Ted Shortlift's textbook. There are also some educational degree programs. Public health informatics is now available as an MPH specialty in a number of places like University of Illinois Chicago and Emory. CDC started and is continuing a public health informatics fellowship. There's an applied curriculum that's been developed by the Public Health Informatics Institute, and so I think you have to conclude from this that what's changed is that public health informatics as a career is a reality. However, there are continuing challenges in public health informatics. First is this vision that I'm talking about today of public health and health information infrastructure integration, which we'll talk a lot more about. Privacy remains a key issue. In 2001, interestingly, there was a recommendation from that meeting to create a National Privacy Advisory Committee at the federal level. Of course, that has not been done, and it's, I think, unfortunate in my opinion. There's a challenge to establish and maintain a two-way flow of data between public health and clinical care. So, for example, imagine public health producing what I call disease report daily for physicians, put on every physician's desk. Here is what's actually happening in the community. I'm sure many of you have had the experience of going to your physician with some symptoms, whatever they were, and your physician says, well, that's going around. Well, the fact is your physician has no idea what's going around and is basing that on a very biased and small sample of patients that he or she may have seen in the office. But your physician could know what's going around with electronic information through this disease report daily. Finally, management of public health emergencies using informatics. This is obviously very important, and we still are in a situation where the data that comes into public health agencies and to CDC about what's going on is typically incomplete and long delayed. And the management of public health emergencies, once identified, I can tell you, for example, that in the anthrax outbreak of 2001, information management at CDC was done with Post-it notes. I was there. Very sad. So, what's the key public health informatics information infrastructure challenge? Well, there was this recommendation in 2001 said the following: public health informatics must create an information architecture that includes a longitudinal, person-based, integrated data repository. Now, if you look at the 2008 definition of a health record bank, it says, an independent organization that provides a secure electronic repository for storing and maintaining an individual's lifetime health and medical records from multiple sources and assures that the individual always has complete control over who accesses their information. Sounds pretty similar. We're going to talk more about that. So let's look now, after this assessment of public health informatics, at the health information infrastructure in Lake Wobegon. So what's the goal? And basic informatics principle for all of you who are learning informatics and those practicing as well, you need to carefully define what your goal is. Because otherwise, it's essentially asking the question, what is going to be possible when the system I'm building is done? And if you cannot answer that question, stop. Because you will never be done, because it's like going on a trip with no destination. You never know if you're going to get there. So you have to have a clear goal that you can say is measurably completed. And the goal in this case is comprehensive electronic patient information when and where needed. It's short, and it's specific, and it's measurable. So what are the challenges to meeting this goal? Well, first of all, the information has to be electronic. You have to get all the stakeholders to cooperate. You have to have financial sustainability. You've got to pay for this. And it has to be trusted because healthcare information is very sensitive. And as you'll see, health record banks successfully address all the challenges. Then I'm going to talk about implementation steps and results. So let's talk about this goal. So in order to meet this goal, all the medical records must be electronic. We have to combine all these scattered records into a master record for each person and maintain it. And we have to enable rapid review of this information to be able to produce charts and graphs and enhancement of relevant information, so it has to be structured and computable. And we also are going to need things like automated reminders to improve quality and reduce errors, which our computers are good at if the information is there. So the way I look at these challenges, the challenges to complete electronic patient information, which obviously is the pot of gold at the end of the rainbow, is you have to have stakeholder cooperation, financial sustainability, and public trust. So how do you get these things? Well, first, let's look at complete electronic patient information. The good news is most of the information is already electronic. Labs, medications, images, lots of hospital records. Where's the problem? Problem's mostly outpatient records, which are still mostly paper. And I'm going to stick with my 10 to 15% of physicians having EHRs, even though the data out of ONC says more do, because the last report in the New England Journal about comprehensive EHRs was in that range. So, but regardless, there's no point arguing about this statistic, because no one would argue that the vast majority of physicians do not today have EHRs. And why is that? Well, the business case is very weak. And one study showed that physicians implementing EHRs only get 11% of the benefit. But yet we ask them to pay 100% of the cost. Now, none of you would so much as buy a ballpoint pen that you could only use 11% of the time. It makes no sense. And so this is just not a good business decision for physicians, which is why they're not doing it. If it was a good business decision, they would do it. So the first requirement for complete information is you have to provide financial incentives to create a good business case. And of course, the high-tech incentives have certainly helped in that regard, although I would argue they're not sufficient, and we'll talk about that. But second, you need a single access point for electronic information. So there are two ways to do that. One, or two ends of the spectrum. One is you can gather the data when needed. So you can leave it where it is, and you can fetch it in real time when you need it. And the advantages of that are that the data stays where it is, and you don't have to duplicate any storage. But there's some serious problems with that approach, which unfortunately is very common, which I'll show you. So this is how the scattered model works. You start at a clinical encounter, and there's a patient-authorized inquiry into an index of every place you've been. So that index doesn't have any information except where records are. And then you send out a bunch of secondary queries requesting records to the various places where they are, and they're represented as folders, but of course they're electronic. And then you collect those records electronically, and you create a temporary aggregate patient history. Fine. And then you send that temporary history to the physician, you erase it, and then hopefully that at the clinical encounter, that information is used, the new encounter data is stored, hopefully in the clinician's EHR, and now a new pointer is added to the index, so next time, in addition to querying all the places you queried, you will query that EHR as well. So how, and I call that a local health information infrastructure. So how does this become national? Well, you pick a given LHII, and the patient shows up in a different one, and there's a query between the two of them, and through a similar mechanism, you retrieve the records and send it back to the other LHII. Well, this makes lovely PowerPoint slides. I hope you enjoy my slides. But it doesn't work in practice at all. I mean, you can implement it, but it has serious flaws, such as all health information systems must have 24/7 query capability. This is really difficult, especially for physicians. Imagine the call to the physician at 3 a.m. What's the emergency? Well, doc, we need you to go into your office and reboot your EHR because the queries to it are failing. And I don't want to tell you what the response is going to be, but it's not something you would hear in polite company. So, second, if you want to search the records this way, it's sequential. Why is that? Well, you don't have any way to search the records except to do that retrieval mechanism. So you go to the index, you collect all the records, and then you have to look through it. And then to look at the next record, you have to collect the next one and look through it. And that, you know, computer scientists like me, we call this a sequential search. And computer scientists don't do sequential searches because we like our searches to finish before we die. So this is not going to work. And I can tell you, I'm not going to be the person standing next to the director of health information infrastructure to explain when XYZ medication is pulled from the market, why we can't even identify everybody who's taking that medication for 2 weeks because of this. I'm going to be in another state. And finally, where's the financial alignment for this? Who's going to pay for all this? There's no business model. So in fact, if you look at communities that are relatively advanced with health information infrastructure, and here are 6 examples, if you're very clever, you may discern a pattern of data storage. And the pattern is they all have a central repository because that's what you have to have in order to do anything about this. And the number of operational community health information infrastructure systems that use this scattered or fetch and show model is 0. 0. No one has implemented this in production. And please, don't tell me about the private HIE that has 5 sources of information. That doesn't count. I'm talking about the whole community where you have to have thousands of sources of information that are integrated. Nobody has done that. So why are people even thinking about this if it's so bad? Well, it relates directly to the existing process for how we get outside records. And this is, again, an informatics principle. Warning, students, informatics principle. When you apply IT to any domain, there are 2 ways you can do that. The first way is to automate the way we're doing things already. Now, this is not bad, but you just don't get big productivity increases from this. The second way, where you get the exciting productivity increases, is when you step back, look at the goals you're trying to accomplish, reevaluate what needs to be done to meet those goals in the context of the availability of information technology, and implement things in new ways. Let me give you an analogy. In the airline business, when they first started using computers, what did they do? They didn't do those reservation systems first. What they did was they printed the paper tickets. Anybody here remember paper tickets? Take my word for it. There were these paper tickets that you had to have. And they printed them. They were often written by hand. They used the computer to print them. Now, was that good? Sure. Was it helpful? Yes, you could read the tickets, and so on. Did that improve productivity dramatically? No. Well, it was decades later before you had things like printing your boarding pass, so you disintermediate all this work on the way to the plane. So that's, and you can only do that with information technology. There's no way you can do that manually. So the scattered model, relates directly to the existing process, which is you come to see me, you tell me you've seen Dr. Smith, I call Dr. Smith's office, they fax the records over. So doctors who are not computer scientists, thankfully, I guess, say, well, gee, if I just had a button I could push to make that happen automatically for all the places you've been, wouldn't that be great? Well, the answer is no, it wouldn't be. That's the wrong architecture. So this does not scale, gets worse and worse. It does not allow searching, as I mentioned. And it's an example of automating how we do it now versus using IT to solve the underlying problem. So, to summarize, the reason you don't want to do the scattered model is all the systems must be available for query 24/7. Every system incurs the added cost, so you have to have a system with more processing power, more communications, more software, and so on. The response time is slow because you have to wait for the last system to respond. Searching is not practical. There's a huge interoperability challenge, entire US, actually internationally. And here's the other problem. Records are only complete if every possible data source is operational, every single one. So it's prone to failure. So you need a central repository. You get fast response time, no interoperability between communities because you put all of someone's records in one place so you don't have to communicate anywhere else. You can search it easily. The reliability depends on one system. You control security in one location. The completeness of the record is assured, it's low cost, and the problem with this is public trust is challenging when you put all the records in one place, and you do have to have duplicate storage, but storage is cheap. So requirement number 2, you have to have a central repository. Now, stakeholder cooperation. Anybody thinks all the healthcare stakeholders are going to cooperate over a long period of time and sing kumbaya together? I have some land to sell you in Florida. It's a little bit moist, but you might like it. It's not going to work. And in those communities where they've succeeded in doing this, they're still at risk from somebody backing out. You can't assure this voluntary cooperation. Well, another way you get people to cooperate is you can pay them to cooperate, but of course we didn't have there's no business model for this, so where's the money going to come from for that? So I would argue that to get the healthcare stakeholders to cooperate in this, you have to mandate cooperation, okay? So you can, within the state or on Capitol Hill, near where I live, you can go and ask for a new mandate. Good luck. In our political system, getting anything like this new is very difficult, to say the least. But there's an existing mandate you can use. HIPAA. In this case, HIPAA is our friend. Normally, very few people regard HIPAA as their friend. Except for the HIPAA lawyers and the HIPAA consultants, HIPAA generally is not anyone's friends. But in the thousands of pages of HIPAA regulations, there is a requirement that if patients request their records, everybody must provide them. And the little-known addendum to that, which has been there from the beginning, is that if patients request them in electronic form, and they're available in electronic form, they must be provided in electronic form. And if anyone's interested, I'm happy to give you the specific regulation paragraph, and you can look it up yourself. So the way to get stakeholder cooperation is to have the patients request all the information. Then it has to be provided. Financial sustainability. So how are we going to fund this? Well, the government can fund this. Good luck. You may have heard of these deficits and so on, and so we're not going to have that. Best you're going to get is some startup money. And actually, under high-tech, there's been a lot of that. The healthcare stakeholders really aren't going to fund this because they're paid for giving care, and these new investments, transaction costs are very difficult. Now, the people who should pay for this are the payers and the purchasers. Who do I mean? The payers are the insurers. The purchasers are the employers. And they're the ones that would benefit from having the information available because it's this comprehensive information that really lowers costs. Well, they don't want to pay for it because they're skeptical about the benefits, and they're also worried about these free rider and first mover effects. They don't want to be the first one. So, if you go to the CEO of a large corporation and say, we'd like $1 million to help do the infrastructure in the community, one of the questions you're going to get is, how do I know that this $1 million is only going to be spent on my people? Because that's all I'm responsible for. And you say, well, we're not too sure, and so on and so forth, and they just won't do this. But interestingly, the majority of consumers support electronic records. They understand that their records are not available. And there have been a couple of national surveys where a slim majority say they'd actually be willing to pay something for this, although I'm not sure they really would. They say they would, but at least that's good. It's better than if they said they wouldn't. Let me say that. But so you have to find a compelling reason for consumers to pay, because in order to get consumers to pay in general, you can't just go to them and say, well, this is good for everybody, you should pay for it. There has to be a compelling reason. We're going to get to that. So the requirement here is the solution must appeal to consumers so they will pay, because ultimately that's where the money's going to come from. Now, public trust. This is the most difficult of the issues. And to me, public trust has to mean patient control of information. Why? Because consumers already control information about their records. In fact, in 2 different surveys, 13 to 17% of consumers admit to so-called information hiding behaviors, such as going out of state for treatment or getting a lab test under an assumed name. And if you don't give them control, you can bet all those people, call it 15%, they're all going to opt out, which is bad. But it's worse, Because if 15% of people are irritated about what you're doing, in our country, ultimately, the people are in charge. Now, notice I said ultimately. It often takes a long time for them to express their views. But ultimately, they're in charge, and you cannot do things in our country that 15% of people are absolutely adamantly opposed to. And I give you in healthcare the example of the unique identifier that was part of HIPAA. 1996, HIPAA passed mandated a unique personal identifier for every American for healthcare. There were hearings in the House, there were hearings in the Senate, signed by the President, everything's fine until the public heard about it. They wrote to their congresspeople, and it was gone in 30 days. So this is not theoretical. If you try to do something that really interferes with privacy, people will come shut you down. So the choices we have are the system we have now, which doesn't give us what we need, or consumer control. And this idea that many physicians have that we're somehow going to have this system where we get complete information without consumer consent, that's not going to happen in this country. So forget about that. So the patients have to control access to their information. You have to have a trusted institution. Now, one way to have that is via regulation, like banks, and this is probably impractical, at least in the short term. So the best you can do now is community supervision with a nonprofit, so you need governance by a community nonprofit, at least I think you do. And finally, you need a trustworthy architecture, and I would love to talk to you for a long time about architecture, but suffice it to say you can build an architecture that works. One solution I like is what I call the two-server architecture, where one server has the patient information, can only be accessed one patient at a time, no matter what you do. And the server with the data that is searchable is offline. So nobody can break into that and search because it's offline. So Lake Wobegon looked at these requirements and said, aha, a health record bank would meet these requirements. It's a secure, community-based repository of complete health records with access controlled by patients or whoever they designate, essentially electronic safe deposit boxes. Information about care is deposited once when created. That's required by HIPAA. And the business model, you can put together a business model that allows you to provide additional EHR incentives. In fact, you can provide free EHRs to physicians so that they're much more likely to adopt. And you can provide those on top of the high-tech incentives. And it's simple and inexpensive. So let me show you a short video about that.
Imagine you or someone you care for is rushed to the emergency room and might even be unconscious. Without important medical history, lives may be in danger. Does the emergency room doctor have all of your up-to-date personal health information? Do you? How can you or your doctor get it immediately? If you're like most people, your medical records aren't readily available to you or any doctor. Today, wherever you seek care, a record is left behind. A record you and your other doctors can't immediately access. Until now, no institution has been available to automatically receive and securely store your records and make them easily available when and where you need them. Now there's a way with health record banks, a secure approach to storage where you alone control access to your health information. Think of it like a digital safe deposit box. When seeking care or in an emergency, you authorize an information withdrawal, giving your doctor access to some or all of your records. When care is complete, new records are deposited, and the information can be used to automatically complete time-consuming forms. Health record banks make good sense. You alone control who accesses your personal, private health records. Records are stored in one location and automatically updated when you receive care, anywhere in the world. Your information is safeguarded by the most secure data protection and encryption methods. And with multiple banks available, the choice is yours. Take control of your health records today. This message brought to you by the nonprofit Health Record Banking Alliance, promoting and supporting the development of health record banks.
So let's look at this in a step-by-step form. So in the health record bank, you have secure patient health data files, And at the clinical encounter, the clinician inquires, and then there's a question as to whether the patient gives permission for access. And if the patient doesn't give permission, there's no access. Of course, then there'd be an interesting conversation between the patient and the physician. But the patient is entitled to give access or not. Of course, the overwhelming majority of patients are going to give access because they want their clinicians to have their records, and so the records are delivered. The new data produced is stored in the clinician's EHR, and now that new data is deposited in total in the health record bank, so it's immediately available to subsequent providers, and you can optionally send money to the clinician's bank for this deposit because it has value, and or you could actually pay for the EHR system the clinician used. So the rationale for this is simple, and simple is good. The records are immediately available. New records are deposited when they're created. It enables all sorts of value-added services, research queries. The patient control results in trust and privacy and also stakeholder cooperation. This is very low cost to operate, and so that facilitates many different business models. And among other things, you can create EHR incentives options like paying for deposits for docs who have EHRs now, or for those docs that don't have EHRs, you can provide cloud-based EHRs. So here's a business model. So if you have 1 million subscribers, you can operate a very nice health record bank for $6 per person per year, $6 million, probably much less. And you can, the cost of those EHR incentives for all the docs taking care of those 1 million people is about $10 per person per year. Where does the revenue come from? First, there's advertising to consumers. You can earn about $6 a year from advertising, or the consumers could opt out by paying a small fee. But the key revenue comes from reminders and alerts. Remember, I said those have to be compelling. So here are 3 examples of compelling reminders and alerts. First, peace of mind alerts. What does this mean? If your health record bank data is accessed by an emergency doc, your loved ones would be notified instantly. Everybody I talk to would be happy to pay for that, and thinking, you know, $20 a year, people want that. And if you're not happy to pay for yourself, your loved one will pay for you, and you'll pay for them. Second, preventive care reminders. So I call this prevention advisor. So based on your demographics in your record, you're notified it's time for your colonoscopy, et cetera, et cetera. Not everybody would pay for that. Actually, the third-party payers should pay for it because they want you to be reminded about those things. But some people would pay for that. And finally, medication reminders. What I'm talking about are refill reminders. So you get a text message at the end of the month, time to refill your Lipitor. Do you want us to do this? Text us back Y or N. So you say Y, send, and the refill's taken care of. Now, the great thing about that is for all the brand name drugs, pharma will pay for that, so it's free to consumers. Why? Because it improves compliance, drops money right to their bottom line, totally ethical. Then there's additional revenue from queries, and I put a question mark because that will be slow to develop, but it could be very large. Note that in this business model, what's not here is we're not assuming or trying to capture any healthcare cost savings. There will be healthcare cost savings, but we're not trying to capture them. So how do you organize this? Well, Lake Wobegon set up a health foundation with a community board of directors, and they're responsible for policy, governance, and oversight. And they contracted with the Lake Wobegon HRBA Corporation, which is a for-profit, which was responsible for obtaining capital and operating the health record bank. And they essentially, the nonprofit essentially regulates the for-profit via the contract, and the for-profit gives a percentage of their profit back to the community organization to pay their expenses. And other communities could use the same health record bank operator, so you could have economies of scale that way. So how is this implemented? Lake Wobegon Health Foundation, the nonprofit, essentially brought in healthcare stakeholders and consumers, did oversight, they supervised privacy and security audits, they established an agreement with the Lake Wobegon Health Record Bank Corporation, they implemented the health record bank, provided free EHRs for physicians, there was a profit allocation to the foundation and also a profit allocation to other contributors of data in the community. So essentially everybody got paid for data. Docs got paid for data. Either they got paid directly, they were given free EHRs, hospitals got paid a little bit, labs, imaging centers, everybody got paid. And the HRB Corporation used private capital. And this solved the Lake Wobegon health information infrastructure problems. The information was electronic because now docs all adopted EHRs because they were free, and that took care of the business case. Stakeholders all cooperated. Privacy was taken care of, and through new compelling value for patients, you could generate easily $20 per person per year in recurring revenue, which is more than the cost, so it was profitable. And so what were the results in Lake Wobegon? Well, it's Lake Wobegon. So the results are all the health records are electronic. All the health providers have EHRs. Comprehensive electronic records are always available for care, unlike in the rest of the country. And public health now can promptly detect and respond to outbreaks, can provide this disease report daily for providers, and can do individualized health interventions for the entire population. So you can do mass customization of reminders. And so you can really do proactive public health on an individualized basis at very low cost. So per capita healthcare costs have declined, decision support's being developed and deployed, and the health record bank is expanding to reach critical mass because, of course, Lake Wobegon is rather small. So what can we learn from Lake Wobegon? Well, first thing is, from the public health informatics analysis, we can learn that public health informatics is now familiar to public health professionals, at least most of them. Has been incorporated into public health practice research and learning, and is now a real career path. And that effective use of public health informatics can provide enormous opportunities to improve population health, but most of these depend on having an effective health information infrastructure. And the key challenges for public health informatics are to promote a health record bank health information infrastructure and to follow Lake Wobegon's example, establishing this new paradigm for health records. And so the key lesson is, as I said at the beginning, public health informatics can reintegrate public health with healthcare by building health record banks, leading to healthy people living in healthy communities, like Lake Wobegon, where patient engagement is strong, all the EHR interfaces are good looking, and all the health information infrastructure is above average. Thank you very much.